Hi, and welcome to the McGregor Dementia Support Ministry Podcast, a podcast providing relevant resources to those currently walking the dementia journey with their loved ones. Today's podcast is a session that was recorded from our Alzheimer's and Dementia Seminar held here at McGregor Baptist Church on February 22nd, 2025. And today's podcast session is a Q&A panel discussion where I had the opportunity to sit down with our two keynote speakers, Dr. Shaw and Dr. Mast, to ask them questions about dementia and Alzheimer's that were brought to us from our audience. I know you're going to really enjoy this session. This is a part of the seminar that we're wrapping up with, but I perhaps am the most excited about because we're going to take many of your questions that you have turned in today, as well as many of you submitted questions when you registered, and we were able to kind of get a hold of those and get started using those questions as well. And it's interesting that a lot of the questions that were submitted prior to the seminar have been answered multiple times during the seminar, and so we won't even really need to touch on some of those. But I love the fact that that folks had certain questions, and they had them, hopefully, if they were listening, had them answered either between y'all's talks or some of the other speakers that spoke today. But so excited to have both of you up here as we have a chance to go through some of these questions. Dr. Shaw, let me ask you this first. Why does it seem, and this was a question that was turned in this afternoon, why does it seem that dementia Alzheimer's is significantly more prevalent today than, say, even 20, 25 years ago? Or is that just a false perception?
Well, I think two reasons. One is that our population is aging, and there are more people who are developing dementia because of the aging population. I also think that Dr. Mast had on one of his slides the new drugs we have now are the first advance since, I think, 2003. So when you don't have new advances in a disease, new changes, new scientific discoveries, maybe you just don't talk about it as much. And dementia is much more in the news because of these new targeted drugs that we have that, although they're not a cure yet, they're at least slowing the progression some. It's a start.
Yeah.
So I think that would be my two answers.
Anything else, Dr. Mast?
No, I agree. I think those are the things. People are living longer. Age is the biggest risk factor, and I think we recognize it earlier than we used to. Right. When I first started out doing memory testing with people typically showed up and they were already in the moderate stage by the time they got testing. And now I'm seeing a lot of people who don't have symptoms and are just worried, and people are being more proactive, I think, about this.
Dr. Mast, what about this question that someone turned in? My mother has early onset Alzheimer's. What do I need to do to prepare for when it gets worse? Is there anything I can do, like around the house or planning ahead now?
Yeah, I mean, I think there are many things that you could be doing to prepare. Some of them were touched on a little bit earlier in terms of, preparing things legally, thinking about having that conversation, while she can about what she would want for the future. I think there are very practical things to be thinking about. So as people move through the stages of dementia, they lose the ability to manage their medications and money well. So maybe getting your name added to a bank account so you can keep an eye on finances, keeping an eye on medications. And, I think Dr. Shaw did a nice job of talking about some of the other changes that can go along with this. You might want to think about how accessible is this home and what happens if there's a broken hip. And you kind of want to be looking around and trying to identify what might be the safety issues. Yeah. But this may be not what the question is aimed at, but I think there's a sense in which also preparing, you want to be looking for who is going to be my source of support as a caregiver or a care partner, because going alone is nearly impossible, right? And you need other people, and if you have other people to talk these things over with and to provide support, your ability to respond to some of the challenges that come up will be better.
Yeah. Yeah. Anything else?
Yeah, I just would emphasize, I think, one thing that Dr. Mast said, that assessing the home environment is a really important thing. Just as an example, I'm working with a family now, and the fellow was diagnosed with very early stage Alzheimer's disease. He had some memory loss and some other functional changes. And so he and his wife asked for a family meeting. So I actually went to their home, met with them and their 2 adult daughters. And by being in the home, seeing they had no main level master bedroom, they only had a powder room on the main level. And so they weren't going to be able to age well in that home. They had stairs and bedroom upstairs. They had a sunken living room that was popular, I think, years ago. So there's one step down. Yeah. And he had already had 2 falls. Oh, thankfully, didn't break a hip. But yeah, I think being proactive rather than reactive. Yeah. And then all the other things Dr. Mast said, I think are real important.
This next question, I'm going to give a little personal example. But the question was, how do you address or talk through confused memories with a person with dementia? Do you clarify or do you just move on? And my mother, who has dementia, we were talking with my sister-in-law. They live with my brother and sister-in-law in Alabama. And one of the most recent things was she had come in to tell my sister-in-law that she had this photo that she was having trouble finding. And said, well, what's this photo of? And she goes, well, it's a photo of Macy, my wife, and she's standing in front of a lake with an alligator, but she's kissing someone other than my son, Mark. And so my sister-in-law is kind of upset to hear that, how dare them insinuate that Mark is, or that Macy's kissing somebody other than her husband, Mark. And so that's a good example of a confused memory. And so she couldn't find the photo, of course, but things like that happen. And I understand the person that asked this question. This happens a lot. What's the best way to respond with that kind of a situation? Who wants to go first?
Yeah, I think this is going to sound like a psychologist, but it really depends, right? And let me clarify. There is a sort of a line of thinking in 2 lines of thinking. One is sort of reality orientation, right? If a person has a misremembered thing or a false belief, we have to correct it and bring them back to reality. That's the fairest and most loving thing. And another approach is sort of to try to validate what the person is experiencing and why they might be asking that question. And so, an example is, one woman that I knew was in a day center, and she would get anxious throughout the day, ask the same question over and over, and wanted to know, when her mom is going to pick her up, right? And so she's very disoriented in another time, and her mom has passed away, right? I mean, this woman is in her 70s and 80s. And so a reality orientation is to say, well, your mom died many years ago, and she's not going to come pick you up. It's going to be your husband. And that might seem very natural, but in that moment, what she's wanting is some comfort from somebody who she loves, and she may not remember that her mother is gone. And confronting her with that reality relives that trauma of losing her mother all over again. And so this sort of validation approach then tries to go with the feeling that's underlying it, right? Mm-hmm. She's looking for somebody familiar who's going to take her from this day center and go home. So this validation approach tries to get at what is the feeling behind the question, and can we validate that while kind of redirecting the person? But I say it depends because sometimes people will have a false belief that we absolutely feel like we have to correct, right? So, you talked about the delusion of, an adulterous spouse. I think if that were me, I would want to correct that and say, of course not, I would never. And that's why I say it depends a little bit, and I wouldn't want to redirect. But anything you want to add?
Yeah, no, I would. Well, yes, I'll add a few things.
I hope you will.
Really, just to extend what you said, Dr. Mast, it makes me think of a client I had as a woman who was caring for her mother who had Alzheimer's disease. And the woman came in and she says, I'm so frustrated with my mother, we argue all the time. And it was over this sort of, the woman with dementia would talk to her mother and would tell her daughter, well, I've talked to mom. Well, this woman's mother had died years and years ago. I mean, the woman was in her 80s who had dementia. And I think what you said is really the important thing. It's the reason people talk to their deceased family members is because they miss them. Mm-hmm. And who's the most comforting figure in our life? For the vast majority of us, it's our mother. Mm. So I said to this woman, you don't need to correct your mother and tell her that your grandmother died 30 years ago, but instead focus on the feeling. So this is what I say a lot of times to caregivers is just focus on the emotion. Like, ask your mom, well, Mom, what did you love most about your mother? What did we love most about Grandma? Because that's really what she's trying to recall, is that the loving part of the memory. And I like the way you framed it, Dr. Mast, is, it's not about sort of correcting an incorrect fact, but it's about what's the underlying feeling.
Yeah. And those can be tough to respond the right way in the moment, because you do want to get things right, but sometimes you need to look past that, and I love what both of y'all said about that.
One thing, if I would add to it, is oftentimes you'll get more than one shot at answering these things, right? Apparently that was funnier than I thought it was going to be, but my point being is you will learn, right? So if I respond in this way, this only makes them more upset. So we can learn from our mistakes, even if we're factually correct. Yeah. And if it makes them upset to respond, let's try some different ways, right? Because we want to care for them well and not be fact checkers.
Yeah. All right. This person said, and actually there's two questions that are very similar. If someone is in denial, how can you help them when they decline medication and doctor care, when they get abusive? Another person said, my husband has dementia. He tells me all the time I'm lying to him. How do I respond? So it's dealing with that person that's not the most receptive to the help and care that you're trying to give them.
Yeah, I'll take a stab at that one. I saw that meaningful look there. One of the things that I write about in the purple covered book is a strategy called acknowledge, affirm, and redirect. And sometimes people who are living with dementia, they'll say things or do things, and you're like in a 10-minute standing count, like you have no idea how to respond, and sometimes what our tendency is to just ignore what they've said or done. What I've tried to encourage is that there's usually, as you talked about earlier, there's an underlying reason why you might see that agitated or aggressive behavior. Maybe they're uncomfortable. Maybe they're in pain. Maybe if they wear pull-ups, their pull-up is damp and it doesn't feel very good. Mm-hmm. All sorts of, maybe they're just tired or hungry. So you can acknowledge the behavior or the thing that's happened, even if it's a very negative thing. And then you sort of turn it to the feelings thing. You affirm that person. Say, Dad, I'm sorry you're feeling so grouchy today, but I just want you to know, even when you're grouchy, I really love you. Why are you feeling so grouchy? And maybe after you've heard them, say, well, let's go get some ice cream, right? Because ice cream fixes most everything.
Of course, yes.
But that's just one example of a strategy. And Dr. Mast, maybe.
I think that maybe I hear the first question as, the person that I care for is in denial about things changing, and how can I get them to maybe go get some attention, get this checked out. And that is a difficult situation. I don't want to downplay it whatsoever, but I just want to offer one suggestion, in that sometimes people who seem like they're in denial are actually just kind of terrified about what might be happening. And when you think about something like Alzheimer's disease, we know that it's the number one feared medical condition for most older people. And, one way to deal with your fears is just to, avoid it and deny it and try to move on. And so maybe if we can start from a point of empathy and actually acknowledging that they might be afraid about what's happening, and why don't we at least maybe consider a brain health check-in, right, and talk with the doctor just to make sure everything's okay. Sometimes I think we think if we just say the right words or if we push hard enough, we're going to be able to overcome it. Some people actually cannot appreciate that their memory has changed. The brain has changed their ability to recognize it. You talked about insight. And so you'll get that vibe if you keep asking and it's just a complete non-starter. But I think starting from a place of empathy and saying, I can understand why this would be terrifying for you.
That really, in a lot of ways, answers another question that someone wrote in. How does someone who notices memory dementia concerns with their spouse breach that subject in a helpful and productive way? And so that first, you start noticing those things, how do you? And I think from a point of empathy is the right perspective. Any other thoughts to answer that specific early question that you might want to add, either of you?
I think about, how would I want to be approached if I were, if I were becoming forgetful and I needed to have an evaluation. And it probably wouldn't be, an ideal time would not be right after I made a huge mistake, right? Okay. Or I had a close call on the road. It would probably need to be a time where things were calm and we're having a conversation about how things are going. So maybe picking your moments. I kind of think about, sometimes we step in and there's a little resistance, so, maybe step back again and try it again later rather than just kind of barreling through the conversation. Yeah. When there's some resistance and defensiveness, pushing does not typically take away resistance. Sometimes we need to step back and try again a different way later.
Yeah. Any other thoughts on that? Because I think there are probably some people here with that thought of, okay, I'm going to have that conversation at some point in the future.
Yes, I agree with everything Dr. Mast said. I guess the one thing I would say is that if, let's say, the person had gotten in a couple fender benders, and so there became issues of either their safety or the safety of the couple or the family, if issues of safety sort of come up to the surface, then I think, unfortunately, the white elephant in the room has to be acknowledged, and you have to kind of move the situation forward, even though it can be uncomfortable. Yeah. Otherwise, I completely agree with everything Dr. Mast said.
Let's stay on the safety thing, because that's a big thing as well, and how we address those issues. Maybe it's already been understood that this person is struggling with dementia, and maybe they've even recognized that initially, but now there are certain things that they are doing that they probably don't need to be doing anymore, whether it's driving or cooking or traveling alone or anything like that. So how does one start dealing with the safety? And let's specifically deal with the driving, because I think that's one of the biggest struggles people face, and not wanting to give up that independence, but yet someone knowing they don't need to be doing that anymore.
Mm-hmm. Mm-hmm. Yeah, so as far as the driving goes, definitely the most challenging thing, it represents independence for most of us who live in the United States outside of a big city where you have good public transportation. So taking someone's driving away is a really hard thing to do. I always say, let the doctors or the medical team do it. Let the physician, the physician assistant, the nurse practitioner, let them be the, quote, bad guy or bad gal, so that the family care partner doesn't have to be the one who takes the driving away if that's important. Mm-hmm. We do have some indicators when we do sequential cognitive testing and we see the test scores decline, along with things like, have there been fender benders or moving violations or things. You get a clue of when the person needs to stop driving. Yeah. And then in our diagnosis clinic, we say to the person at diagnosis, even if they just have mild cognitive impairment and they might drive 3 more years or 5 more years, at some point you're not going to be able to drive again. Yeah. We tell them that right up front, and we'll be walking with you as we decide that.
Yeah.
Dr. Mast?
No, I think that's great. I agree with all of that. The only things I would add are, I was going to say the same thing. Work with your healthcare provider. Let them make the decision. This will feel like a lack of trust for some of you, but when you're in a dire safety situation, what some people will do is they will just write a letter to the doctor or the memory care clinic and describe what some of their concerns are. And that's why I said it may feel like that's deceitful or a lack of trust, but what they're trying to do is convey to the provider, we have a real safety issue here, and we don't want to upset them in the appointment so that you can do your evaluation. The second thing I would add is, some cities and health systems will have performance-based driving evaluation programs. Those can be really nice because I can give somebody batteries of memory tests and it will tell me something, but it doesn't tell me how they drive on the road. And some people are convinced they can keep driving and some families are convinced they can't. And so a performance-based evaluation allows them to prove it. This is an on-road evaluation. They're going to screen them before they do it. The driving evaluator isn't going to get into the car with somebody with advanced dementia, but that also takes some of the uncertainty out of the equation and allows a professional to make the decision as well. And I really like that option for people.
Another question that comes up occasionally, dealing again a little bit with the safety, but should I take my loved one's threats of self-harm seriously? And how do I respond when those do come up?
Yeah, I think we'll both probably have thoughts on this. It's very stressful to hear somebody that you love talk about harming themselves. And I think it's always important to take those things seriously. And the question is, what does that threat of harm actually mean? Is an explosion in the moment, a verbal explosion? I think what you want to do is, try to keep your wits about you, try to stay calm, ask some questions. But I would encourage you to enlist some professional help to evaluate that specific threat. You also want to think about what you can do to keep them safe. So for a person who is threatening self-harm, you don't want to leave them alone. You want to stay with them until you can keep them safe. If they're threatening a specific way of doing it, they have guns in the house and they're threatening to shoot themselves, you need to get the guns out of there, right? If it's medication, maybe you need to lock it up. But it isn't your job to necessarily evaluate the seriousness of their threats, but in the moment, you want to make sure you keep them safe and then encourage you, if it's immediate threat, get them to the emergency room if it looks like something that's actually going to happen, but also, maybe just enlisting a mental health provider to work through this with you. It really depends upon, the stages of dementia. Are we talking a really early or something very advanced? It's not a one-size-fits-all, but those are a few thoughts about how I would think about it.
Very much agree with having a mental health provider assist with the evaluation. Somebody saying, I'd be okay if I didn't wake up in the morning. Some family members may be very concerned about that and think that's a threat for self-harm. That's different than someone saying, I'm going to shoot myself, or I'm going to cut myself, or hang myself. So the kinds of questions I think Dr. Mast was alluding to, we do get a better understanding of what they mean by the self-harm, and then do they actually have a plan to hurt themselves, and do they have a means of doing it? So
a lot of different options and varieties there and how to diagnose that question or that statement. Here's another one. You touched on this, I believe, Dr. Shaw, a little bit, but what does physical intimacy look like in marriage that's been impacted by dementia?
Yeah, so physical or sexual intimacy in a relationship affected by dementia, it can actually look quite different. So if the person with dementia has some identity issues, if they don't recognize their spouse as their spouse, obviously they're going to be afraid to have physical intimacy with them, even maybe hugging and kissing. Just simple acts of affection may become more challenged. And so if the person wants to be intimate with their loved one, I say, go slower, be more patient, explain what you're going to do. Many couples, they have a routine of their foreplay before they have sex, but that may not be familiar to the person in the couple anymore. So I say it's just, take more time. The flip side is that the person with dementia, if they're a little bit disinhibited, in other words, if they don't have their usual inhibitions, they may actually be hypersexual. They may want sex more frequently. And so that can be an issue that a caregiver can face as well. So I think when those sort of issues occur, having a professional therapist, if the couple's having trouble navigating it on their own, can be really helpful for them. But I appreciate the question and that we can just talk about it.
Yeah, absolutely. I'm going to change directions a little bit here. This was somebody said that recently they heard a news story out of the Netherlands about people with Alzheimer's over there that are trying to make plans for their own assisted suicide before their decline progresses. How do you think about a story like this and think biblically about it?
Well, it is a thing, right? This is something that is getting more common, and I can appreciate that people have seen other people suffer with Alzheimer's disease. They don't want it for themselves. They don't want it for the people that they love, and so to them it feels like the most rational solution. There's one thing that we really haven't talked about today, and maybe it's implicit in some of the things that we've said, but sometimes this is our knowledge of Alzheimer's is something that we've seen in other people, and maybe we've seen people suffer terribly. But it is also true that some people don't suffer with Alzheimer's. They experience changes, but they aren't as miserable as we think they might be. And so one of my concerns with this is obviously, we want to think about the sanctity of life and the life that God gives us. But I sometimes worry that looking ahead like this and saying, well, I'm going to end it before the suffering begins, cuts off a life that might be still well lived despite dementia. It's a hard question to answer because obviously I value life. But I also can appreciate the suffering that people see and want to, maybe spare their families from it. I'm not surprised that it's becoming a pretty big movement.
Yeah. Any other thoughts?
I'll just add, if you're a movie buff, there's a movie called You Don't Know Jack. It's an HBO movie, and it's about Dr. Jack Kevorkian, who I think most of us remember in the room. The very first person that he assisted in their suicide was a woman with dementia. And the movie is very thought-provoking about the question, and it's a very well-done movie. I think in North Carolina, we are a state where assisted suicide is illegal. I'm personally very thankful for that. In a career of 40 years, caring for people with brain cancer and dementia, had many people ask about, my help in assisting their suicide. Personally, I couldn't do it, and I'm glad that I have a law that protects me from that. I very much see that when a person ends their life is the providence of God and not the providence of a person. But that's just my opinion. Because on the flip side, you could envision it as the full extent of a person's autonomy to choose when they live and die. So it's a hard issue.
Yeah. And I think, hitting back, both of you referred to the sanctity of human life. I think that has become a slippery slope in our culture and around the world where that is no longer the primary thing anymore. And once that goes away, we will see, even our neighbors to the north, how they have continued to relax their, it used to be for medical reasons, and now it just continues to get less and less for the reason. And you don't know where that ends, but I'm grateful that both of you have a desire to protect human life at both ends of the spectrum and everybody in between, right? Let's see. Got a couple more questions here for you guys. Somebody asked just a definition real quick on sundowners. What is that? I know you both referred to that. You gave a little bit definition, but just in case they missed it, how would you define sundowning?
Go ahead.
Sundowning is as the afternoon, with the onset of the afternoon and as the sun begins to set. It's very common to see people living with dementia start having some of these challenging behavioral expressions that both Dr. Mast and I talked about. I don't think we completely understand why it happens, but it's consistently observable. In Rebecca's care, after that point in time I described, could actually see a change in her countenance. Her facial expression would change, how she held herself changed, and we knew the sundowning was coming, and we would have a couple of really difficult hours.
A lot of times we hear the phrase somebody died from Alzheimer's. What do they actually die from when we say that?
Right. You might be, as a medical doctor, in a better position, but...
yeah, either one of you.
Yeah. I mean, I think we see... It's a confusing issue, right? So Alzheimer's is often a factor in shortening people's lifespan, but it can be a variety of other things, an accident, a fall, pneumonia, other conditions. My understanding of this is that at some point people weren't getting Alzheimer's included on death certificates, so it was said nobody really dies from Alzheimer's, and things are changing now. But Alzheimer's can make you more susceptible to other conditions that could, in a sense, do you in.
I think you mentioned the susceptibility. The cause of death for people who have Alzheimer's or other forms of dementia, 40% die from a respiratory infection, from aspiration pneumonia, because late in the journey, swallowing becomes impaired and they can swallow food or fluids into their lungs. And our mouths are very dirty, and a lot of germs go inside and set up for bacteria. And so if somebody doesn't have any of these other complications that Dr. Mast alluded to, that you can actually die of the dementia. Eventually, the disease will cause neurodegeneration in the brainstem, which is what controls your breathing and your heart rate. And once it sort of affects the brainstem, then neither of those things will work.
Yeah. Makes sense. Dr. Mast, you were talking about some of the new treatments, infusions, and tests. Are any of these covered by insurance?
Yes. So this is a rapidly evolving area. So some of the newer tests that I mentioned the one blood test that really just kind of came online last summer. That one is not yet covered by insurance. I'm told the company will pay for it if you make less than $150,000 a year. But otherwise, it's a pretty expensive little test. It's my understanding Medicare is covering the new treatments and some of the PET scans that are needed to make the amyloid confirmation before. But it is going to be a big stress on our health system and our health insurance system. But I think it isn't a clear across the board, everything is covered. I think it will depend on the situation, and somebody was even talking to me about that at a break, that they had the PET scan and they wouldn't cover the treatment. So.
Yeah, I think that's always a concern, especially with, anytime something's new, that drugs are always super expensive, and a lot of times they aren't covered by insurance. And so I'm sure that is going to always be a concern. I'm gonna wrap us up here with this word of encouragement to both of you, because I don't know if we realize how blessed we are to have both of y'all here as our keynote speakers. We've never had two keynote speakers like this before, and God in His sovereignty brought both of you together. You jokingly were saying the Ben and Eddie show. They're going to go on the road. It's not Ben and Jerry, but Ben and Eddie. And so blessed to have both of you and your wisdom and just your attitude, your humility, and your desire to serve the body of Christ and His kingdom. We are blessed to have you both here. Give them a wonderful round of applause.
Thank you for listening to this podcast. Please subscribe to this channel if you've not already done so, and leave a review if you found this content helpful.